Hello, my name is Hope Schlesinger and I'm a trainee clinical psychologist at the University of East Anglia in the United Kingdom. The topic of this talk is screening for low mood and suicidality when working with individuals with aphasia. Myself, Professor Neil Broomfield, Dr. Kat Ford and Kira Shiggins are currently conducting research in the UK on how staff screen for low mood and suicidality in those with aphasia. As well as exploring the kind of barriers and facilitators to screening when working with this client group. Therefore, in the next 15 minutes, I will be talking about post-stroke aphasia rather than aphasia as a result of other ABIs. However, before I start, I just wanted to take some time to thank Aphasia Access for organising this event. I'm very grateful to be part of the 24-hour virtual teach-in. I think it's an inspired idea of keeping us all connected at the moment and for keeping the kind of conference spirit alive. So before I start, I actually wanted to share with you some famous pieces of artwork that all have something in common. And I wonder if you can spot what links these pieces of work together. So this is Damien Hirst Pills. This is The Scream. This is Pablo Picasso from his Blue period. It's the old guitarist. This is Tracy Emin's Messy Bed. And this is Vincent van Gogh, The Distressed Man. These are all actually artist representations of depression. And I guess for me, what they show, well, they kind of show two things. One is how difficult it is to talk about depression without words, how to represent depression without using vocab. And I think it also represents for me the individual experience of depression and how complex of a phenomenon it is. They all represent different kind of facets of what we would call depression. And I think it kind of introduces this topic well of trying to discuss depression when someone's communication is impaired. Obviously, artists have looked at it, but also researchers had looked at this topic as well. And they have found that individuals with a stroke are at increased risk of depression than that of the general population. And there's also a significant amount of research now to demonstrate that those with aphasia are at even increased risk than those who have had a stroke who haven't developed aphasia. Depression has a number of significant and damaging impact on individuals' lives. It's associated with reduced progress in rehabilitation, a shortened life expectancy and reduced quality of life. And the very nature of depression means that there's a predominant feeling of feeling low, of feeling isolated, reduced motivation, reduced pleasure in things that once brought people joy. As a result of this, multiple health guidelines now recommend screening all stroke survivors for depression because of this increased risk, but also because of the really negative impacts it can have on individuals' lives. And I guess without screening, we won't be identifying cases with depression, and if we're not identifying them, they're unlikely to be receiving care. However, I'm going to read this quote directly. A recent executive summary of post-stroke depression, it's by Rogers, I'm just going to read her quote, stated, "One would assume that a patient with stroke are routinely being screened for depression in our healthcare facilities. Sadly, however, this is not the case. Many patients with stroke are never screened for depression." It feels important to add that practice will of course vary from service to service, and there are definitely services that screen all stroke patients for depression. Researchers have began to look into why there's variation between kind of theory and practice and variation between services. So Hart and Morris looked at what kind of barriers and facilitators there were to try and increase compliance with screening. So this was in 2008. They found that compliance would be enhanced by training to increase knowledge and skill in this area, providing evidence for the utility, so the usefulness, what's the usefulness of screening, increased awareness of guidelines, support from other colleagues, and integrating mood assessments into job roles, job plans, and routine assessment processes. I guess this research doesn't look specifically at those with post-stroke aphasia, and it is likely that screening for depression and suicide in this client group looks quite different. Traditionally, depression is most commonly screened by an interview or a written questionnaire, for example, patient PHQ, the Patient Health Questionnaire, or the BDI, the Beck's Depression Inventory. And this reliance and dependence on written and verbal screening tools make them unsuitable for people with aphasia, and therefore likely practice of screening in this client group will look quite different. Also, there are unique barriers at play with this client group because of the innate communication difficulties that is the hallmark of aphasia. So, for example, there are different screening tools that are more commonly used. So there's a visual analog scale, there's the distress thermometer, and these rely less on verbal and written communication and use images to represent a scaling of mood. There's also screening measures that have been designed with those with aphasia in mind, so the stroke aphasic depression questionnaire, for example. And so again, as much as Hart and Morris's research was really helpful, it didn't look at the kind of unique elements in this client group. I mentioned before that there are kind of unique barriers at play. So there has been research looking at barriers in services and how they impact those with aphasia. And these researchers found that in stuff like inaccessible information, staff attitudes, or unskilled communication partners meant that those with aphasia can receive poorer healthcare. And these barriers highlighted are likely to be in play when screening for mood as well as general delivery of a service. But this has not been formally researched. So what our research is hoping to do is kind of fill this gap. So to gather information on what screening looks like in this client group. So firstly, how regularly it's happening, what professionals do the screening, what tools do they use adaptions, as well as exploring the barriers to see if there are relevant barriers and facilitators, ones that are consistent in stroke services and ones that are unique to those with aphasia. So as a result, myself, Professor Neil Brimfield, Dr. Kat Ford, Dr. Kira Shiggins, and also with support from Ian Kneebone and a small group of stroke staff, we created a questionnaire that we are currently rolling out here in the UK to answer some of these questions, to gather some data on screening practices in post-stroke aphasia, when screening for depression and suicidality. And I just wanted to say a little personal story of how I came to do this work. So I used to work in London in a neuro rehab service, and we had, it was a multidisciplinary team, and one of my speech and language therapist colleagues has been working with a gentleman, and she'd actually moved jobs, so she'd seen him on the inpatient ward and now was following him up in the community, and had undergone a significant amount of rehab, speech rehab, from when he first had his stroke. He was unable to use his voice to communicate, and by the time we got to, he was able to communicate using his voice. And she was undergoing a process of rehab involving stuff like being able to communicate with his partner or ask for a cup of tea, things like that. And what he was choosing to use his voice to say consistently was that he was feeling low and that he wanted to end his life. And I think I can say us as a team felt very underskilled in being able to support him. And it also involved a huge amount of interdisciplinary work between myself and the speech and language therapist to be able to support this individual. And I think I went away and did some research to try and support him, and found that there were gaps in the literature, and that this wasn't just a problem that us as a service was finding this work difficult. So when I went on to start my clinical psychology training, this was the topic I came back to for my research, to try and develop support the development of the literature for individuals like this man I worked with all those years ago in London. So as I say, that was kind of my journey into this piece of work. And I'm sure there's loads of other individual experiences of working with people with aphasia who are experiencing low mood. And that's kind of what I want to capture in this research. So if you do work in the UK, if you have worked with either one or many people with post-stroke aphasia, we'd love to hear your experiences of engaging in that process. statement, the NICE stroke guidelines, and the depression after stroke guidelines there as well, if that's something of interest to you. And that just brings me to the end. I just wanted to say, thank you again to Aphasia Access for organising this, and thank you for taking the time to listen to me today. And I hope the rest of the 24-hour teaching goes well for everyone. I'll just leave that up on the screen to end in case you'd like to take part.